At the offset, I would like to thank the organizers for giving us the opportunity. And since the presentation is very short, I will just take 1 minute to talk about नीव. ये जो इतनी सारी खुदाई करके हमारे यहाँ जो मैडम ने और सब ऑर्गेनाइजर्स ने 350 नीव की ईंटें रखी हैं और इस बुनियाद को बनाया है. मुझे लगता है कि हम लोग वी आर दी फाउंडर पिलर्स, फाउंडर स्टोन्स ऑफ दिस मिशन. And this is just not only a mission, this is a movement of sharing our mind, movement of sharing knowledge with each other, and movement of for sharing hands, so that we all can work for one mission, zero mortality for preventable deaths. So I think at the end of today's this mission program, we all have to join together and थिंक कि हमने जो आज एक इतना इम्पोर्टेंट अपनी प्लेस दी है, हम आज नींव का पत्थर बने हैं, तो हमें इस हमारे मिशन की बुनियाद को आगे ले जाना है. ये कोई बहुत छोटी चीज़ नहीं है. If we are present there today in this Lady Hardinge Hall, this is an opportunity for all of us. Incidence of twin pregnancy is increasing due to ART techniques. High risk category itself twin pregnancy is because of preterm labor, malpresentation, postpartum hemorrhage, and of course retained placenta, which is 3 to 5% more in cases of twin deliveries. 2 lives, 1 delivery, double the joy, double the vigilance. So we have to be very particular whenever we are delivering a twin pregnancy. Just a small case scenario. 30 years old, gravida 2 para 1 woman with dichorionic diamniotic twin pregnancy, delivered twins at 36 plus 4 weeks by normal vaginal delivery, placenta not delivered after 30 minutes despite oxytocin, continuous trickling of blood is there, uterus is firm but irregular. So our provisional diagnosis comes as retained placenta following twin delivery. What are the possible causes? Placenta adherence, TEB placenta, adherent placenta. Why we call it as a retained placenta? Because it is not delivered within 30 minutes. There is no cord lengthening or gush of blood. There is continuous mild bleeding. Uterus is firm, irregular, suggesting TEB placenta. Now, what are the 3 main? The placenta has separated from the uterine wall, but because of the premature closure of the cervix, that separated placenta lies just above the cervix. Placenta adherent is a condition where placenta, because of large uterine surface and over distension of the uterus, it does not the uterine tone and contractions are not enough to follow the physiological condition, and placenta does not separate from the uterine wall because of this, and it is called as placenta adherens. And third is adherent placenta. We know because of the abnormal myometrial and placental intervention, there is placenta accreta. There may be a retained lobe also, or there can be a partial inversion of uterus also. Partial inversion of uterus we can easily differentiate because there will be shock out of proportion of the hemorrhage which is there. So next, so once the condition is there, first point comes is the initial assessment. We have to check the vitals, pulse, BP, uterine tone, vaginal bleeding, ensure resuscitation setup, uterotonics to be given, confirm that oxytocin, ergometrin, misoprostol use availability is there, palpate the uterus. This is the main point. We have to see whether it is contracted or boggy. If it is contracted, it means separation of placenta is there, and if it is boggy, means placenta is still adherent to the uterine wall. Inspect the cord, whether it is intact or it is avulsed. Immediate management is resuscitation. As since morning we are listening how to go in for an emergency whenever there is any problem, call for help, check vitals, start IV lines, send blood for complete blood examination, cross-match coagulation profile if there is PPH, begin IV fluids and oxygen. Control bleeding as usual as we do in any case of hemorrhage, oxytocin, methyl ergometrin, misoprostol and so on. Then very important again, as I said, Evaluate uterine tone. If it is firm, that means it is a trapped placenta. It is boggy, adherent placenta, or atonicity is there. Perform gentle controlled cord traction with counter pressure. Then why the trapped placenta I have already discussed. Now it is very mandatory that after delivery of the second twin, the cervix may constrict prematurely before the placenta is expelled, leading to trapped placenta. This leads to a trapped placenta. So how to manage a case of trapped placenta? Give uterotonics so that upper uterine segment contracts. After that, try digitally to open, or with the help of instruments, to open the cervix and pull out the placenta. If it is not possible, then do this procedure under anesthesia so that already separated placenta can be taken out from that closed cervix. Then we all know about the procedure of manual removal of placenta. I need not to go into details, but what has to be done once we have done the manual removal of placenta? We have to see the vitals, monitor vitals and uterine tone, continue oxytocin for 2 to 4 hours, administer antibiotics. Now, what is the role of ultrasound whenever there is a case of retained placenta? We can see before expulsion, before doing the procedure, we have to see whether it is an adherent placenta. The type of ultrasound findings will let us know that it is a morbidly adherent placenta, or it is a partially separated placenta, or it is a part of placenta which has remained inside the uterus. Then after the complete ultrasound examination, we have to check the placenta which has expelled out, whether it is complete or it is not complete. Documentation. Again, documentation is very important. We have to write all the delivery notes in detail, in time, order, presentation, Apgar, placenta count, record of uterotonics, estimated blood loss, and interventions. Operative notes should be complete if the MRP is done. Then, so now we have come, the whole thing, we have come done the documentation. Now comes the follow-up care of a patient where there was a retained placenta. We have to counsel her regarding postpartum contraception, about the next pregnancy. The risk of recurrence is there. The delivery has to happen in the hospital. Early third stage vigilance has to be there in the next pregnancy, and in any of the time in between two pregnancy, we have to avoid unnecessary curettage. The main cause, again, morbidly adherent placenta. Whenever we are doing a MRP and we are not able to find a cleavage plane, we have to suspect placenta accreta. Avoid forceful separation to prevent hemorrhage. Immediate senior help is required, and a surgical readiness has to be there for laparotomy and, if needed, hysterectomy. And if we want to have a conservative management, leave in situ and give the patient methotrexate. Placenta accreta spectrum is higher in twins because of assisted reproduction. Nowadays, more of the twins are there because of this. Previous cesarean or curettage, and because of large placental surface. Now, why, just a simple line, that why there is more retained placenta in case of twin pregnancy. The first point is there is uterine overdistension. Uterus is overstretched to accommodate two fetus, two amniotic sacs, and a larger placental mass. After delivery, the uterus does not contract at all, it contracts inefficiently, leading to poor shearing force, which separates the placenta from the uterine wall. Result is the failure of placental separation. So, these were all I have discussed already. Now, one thing is very important in case of twin, that while delivering the second twin, it is the management of the second twin which matters in having the retained placenta or not. Palpate abdomen and do quick per vaginal examination. If longitudinal and vertex, allow descent. If breech extraction. If transverse, external, internal version. Avoid delay beyond 10 to 15 minutes. After delivery of both the twins, watch for uterine contraction and do active management of third stage of labor. So, to prevent retained placenta, we have to do active management, and this is critical to prevent atony. facilitate placental separation and reduce retained placenta chances. So key learning pearls are: always ensure the second twin is delivered before managing the placenta. Twin pregnancy, higher vigilance for uterine atony and retained placenta. Never pull on the cord without a contracted uterus. 30 minutes is the threshold. Ultrasound guidance post MRP is invaluable in confirming the completeness of the procedure. So, timely diagnosis, watch for uterine atony, intervene early with uterotonics, no traction without contraction, resuscitate and prepare for MRP, ensure asepsis, check that both placentas are there, accreta suspicion if no cleavage plane is there, note all the findings and document them, evaluate postpartum the condition of the patient, and documentation and counseling.